Black women in the United States are 2 to 3 times more likely to experience a serious problem in labor or delivery, and 3 to 4 times more likely to die from it. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Executive Speechwriter with AHA. In this Members in Action podcast featuring maternal and child health efforts, Aisha Syeda, Program Manager at the AHA, is joined by 2 leaders from Northwell Health. Dr. Viktor Klein is the System Director of Quality and Patient Safety for OBGYN at Northwell Health, and also the Vice Chairman of OBGYN at North Shore University Hospital. Dr. Adriann Combs is the Clinical Director and the Associate System Director of Quality and Patient Safety of the OBGYN Quality and Patient Safety Department at Northwell. Doctors Klein and Combs will share how launching the Maternal Outcomes and Morbidity, or MOMS Collaborative, has increased awareness of maternal health complexities and reduced disparities in maternal care.
Thank you, Tom, and thank you, Dr. Klein and Dr. Combs, for being with us here today. To start us off, can you give us some background about the Maternal Outcomes and Morbidity Collaborative, also known as the MOMS Collaborative? What's the goal of this program and what does it offer to new moms and their families?
Our Maternal Outcomes and Morbidity Collaborative was based on the pervasive national problem, seen around the country of disparities in death related to pregnancies. That hospitals know how to protect mothers, we're just not doing it right. If we look at trends in the U.S. and New York State, that we learned that maternal deaths are increasing in every category, and Black women are 4 times more likely to die in New York State compared to non-Black patients. This would be the categories of hemorrhage, preeclampsia, DVT. What are the U.S. leading causes of death, morbidity, and mortality in the United States and disparity? If we look at hemorrhage, if we look at infection, if we look at mental health conditions and coronary artery disease and heart disease in women, there's really not a big difference. But if we looked at cardiomyopathy, preeclampsia, and embolism, that these rates are much higher in the Black population compared to the white population. And it's something that we have to deep dive into and try to figure out why this is happening and really level the playing field. That based on race, based on color, it does make a difference that you get the same outcomes. We also know the rising cesarean section rate. When I was a resident 30 years ago, it was 15%. Now it's over 30% for primary cesarean sections. Current efforts across the country, AIM, ACOG, New York State Department of Health, Greater New York Hospital Association, SMI, the Safe Motherhood Initiative, New York State Perinatal Quality Collaborative, the New York State Task Force on Maternal Mortality and Disparate Racial Outcomes, have all looked into this to try to decrease maternal morbidity and mortality for all patients.
Although we've worked closely with all of the organizations nationally and within New York State and within our own system, we recognize the fact that although we've done pretty well at recognizing when patients arrive at the hospital, what their problems are, we know that severe maternal morbidity can occur at any time during pregnancy or the postpartum period. So we need to innovate. We need to do things differently than we had done them in the past. And we also know that in the literature that over 60% of all severe maternal morbidity is preventable. So as a group, we decided that we needed to innovate. We needed to do things somewhat differently than what we had in the past. And that was the beginning of the Maternal Mortality and Morbidity Collaborative. And the goal of our program is to decrease the incidence of preventable maternal morbidity and mortality in the community we serve, and then share whatever lessons we've learned so far, and we'll talk a little bit about that today, with the New York State community and then nationally through presentations and publications through the OBGYN world. What we have gotten very good at recognizing and dealing with is when a patient shows up with severe maternal morbidity. The goal of the MOMS Collaborative is to identify morbidity early in pregnancy so the trajectory of the pregnancy and the pregnancy outcome can change. And how are we doing that? And what are we doing to differentiate ourselves? We try to prevent what we know is preventable. That's recognizing risk for hemorrhage, recognizing risk for postpartum preeclampsia and for depression. We also recognize that we need to look very closely at the role of race and ethnicity in determining our outcomes. So developing a set of data that can help us then delve more closely at some of the risks that may not be so readily identifiable. We want to be able to proactively manage comorbidities, and this is being done right now through the Moms Collaborative, through a big initiative to improve the recognition and prescribing of low-dose aspirin for women at high risk for preeclampsia. So early in pregnancy, after about 12 weeks gestation, women that are recognized to be at high risk for poor outcome related to preeclampsia are started on low-dose aspirin, and we know using low-dose aspirin in these patients can dramatically decrease the incidence and severity of preeclampsia. And we know that preeclampsia right now affects about 4% of all pregnancies, and we know that preeclampsia can lead to cesarean section, preeclampsia can lead to preterm birth, preeclampsia can lead to growth restriction in the fetus. So utilizing this sort of format and this sort of interdisciplinary, multidisciplinary collaborative to get our message out, not only to our providers and our physicians, but to our patients and then the community as a whole. The other part of this is recognizing our own biases. Implicit bias and racism plays a role in health outcomes for Black women and Black families throughout the country. A big part of our initiative is improving our own awareness of biases, including implicit bias and racism training for our faculty and staff. And then also in looking more closely at the landscape of maternal health. So not only within our own OBGYN department, but our women at risk for poor behavioral health outcomes, making sure they're hooked in with behavioral health subspecialists during pregnancy, and then for our preeclamptics and our women with pre-existing heart disease, making sure that they see cardiology, if not during pregnancy, soon after, to change, again, their own future risk for cardiovascular disease. So our goal, as mentioned previously, is to reduce the incidence of morbidity and adverse events and subsequently reduce our disparate outcomes. And for our patient and our providers is to improve the patient and provider experience. And this is done through education, empowerment, and enhanced services, which we'll talk a little bit about the navigation component of the MOMS program as we move along. So what makes this different is that we want to provide a truly integrated patient experience based on high clinical quality and reliability. And this is all supported by patient-centered technology, which we're going to talk about a little bit, and individualized care navigation. So we use case managers and care navigators for our patients at the highest risk. So boutique sort of concierge-like services for not those that are most likely to be able to afford it financially or have the best community resources, but for those at the highest risk for poor outcome.
So what was the impact? What was the lessons learned? So we set up something similar to Six Sigma, a multidisciplinary team of executive sponsors, project leads, steering committees. We had a project manager, and we had three main committees: data and analytics, best practice, and education and awareness. And then we were leveraging our system to provide truly integrated care. We looked at unplanned ED and OB triage visits. We looked at delivery admissions, postpartum care. We started a new parents program, interconception care, and prenatal care. So we looked at all of these aspects of maternity care. The core components of the MOMS program: number one, to develop best practice approach to prenatal care, utilizing individual patient assessments and risks. Second, integrate the multiple parallel services and initiatives available to our patients and providers to decrease redundancy. Third, to develop a digital platform to educate and provide automated navigation through the pregnancy journey. The fourth component was to provide care navigation for patients at increased risk of morbidity. Fifth, seamless integration into the new parents program. Next was become the central repository of grant and research initiatives. Next was to develop a robust database to investigate outcomes and track KPIs. Focus study on potential etiologies of disparate care, and integrate with community-based organizations in this space. When we establishing best practice for moms, early identification of people risk factors. So patients at increased risk of preeclampsia, eclampsia were identified and given aspirin early in pregnancy to decrease the chance of the development of preeclampsia, eclampsia. We did a comprehensive risk assessment, which was embedded into the electronic medical record to look at anyone increased risk of hemorrhage, increased risk of preeclampsia, hypertension, diabetes, and VTE. And we developed a robust screening and data analytics to just look at all of these issues to see if we're making a difference.
One of the more innovative things that we've developed is what we have a digital platform. It's called the Northwell Pregnancy Chats. It provides any of our patients right now can text to this chatbot platform with some basic information about themselves and their due date. And on a regular basis, it provides educational material to the patient. In addition to the educational material, via the chatbot, there's a way to escalate initially to an electronic source, but then escalate further to human if the person is having any problems. There is no login. They don't need to download anything. They do receive emails or text, depending on how they tell us they want to get their information. There's always personalized patient education and support based on responses to their questions. And then there's direct connection to during the day, during the week, to our navigation group, and on the weekends and overnight. It connects to our clinical call center, which will help the patient either give them information to allay their anxiety or find them their provider if they're struggling to get their provider in the middle of the night. This is a new add to our system. We're anxious to see how this is going to help our patients. We're hoping this helps reinforce what the patients are learning about in their provider visits. We hope it's going to help prepare patients to be ready for their provider visits. And as Dr. Klein already mentioned, the risk assessments that are embedded into our electronic medical record are also going to be embedded into the chats. So if a patient risks in for preeclampsia, some of the messaging might be around that. Wow, you might want to, next time you go to your doctor, you might want to talk to them about what preeclampsia is and what your risks may be, to sort of provoke that conversation to the place where the patient is more in control and in charge of their pregnancy journey moving forward. As mentioned, the program will be introduced in the provider's office. They have an opportunity to register. There's going to be standardized education and risk assessment. Education is going to be reinforced by what they learn in the physician offices or provider offices. There's additional ad hoc patient interaction as the patient wants with the platform. And then there's, as I mentioned, a capacity for escalation. And then based on that escalation, either reassurance that everything's okay, there may be a referral to an emergency room or to the labor and delivery, and a referral to a physician. And that episode may be resolved, or we may have identified a patient at increased risk for a poor outcome. And these patients will then have the concierge-like service that I mentioned, where they actually will be followed by a case manager to help them through the rest of the pregnancy or the postpartum period to make sure they're able to get what they need, understand what their problems are, and follow up with their doctors as requested. One very important part is the navigation piece that I mentioned. I'm just going to tell you a little story about a patient we actually navigated. This was a 23-year-old Gravida 1. She was admitted in the summer of 2020 for elevated blood pressures by an MFM consult. She had a cesarean section 3 days after her admission, and she left against medical advice a couple of days after that from the ICU because this was with COVID and her partner was not allowed to stay with her. So she decided that she needed to leave. Her blood pressures were not on good control without medication, and she left with her BPs in the 170s to 180s over 100s, and she left without medication, and she left without full evaluation. So as I mentioned, she left without her medications, and she was then told us when we finally got in touch with her, she was unable to get them from the pharmacy where they were prescribed. This prescription was sent. She also left her blood pressure cuff in her car at the hospital because she had left and she was staying with her mom about 1 hour away from her OB practice. So what did the care managers do? They got in touch with her. They assessed her for clinical decompensation. They followed up and provided community for the support services. They reinforced the importance of medication and the treatment plan. So what happened was they educated her on the signs and symptoms of her preeclampsia. We got her blood pressure cuff back from her car. Her meds were transferred to a pharmacy closer to the patient so she could go and pick them up. She actually had an appointment made that same day for a blood pressure check in a local high-risk clinic where she was. And she was offered for further management an opportunity to work with our women's heart health services related to her ongoing risk for poor outcome related to her cardiovascular condition. I think what's really important and what we've learned from our navigation system so far is the navigation program was actually implemented during COVID. We initially followed our moms that were COVID positive for after discharge. It has morphed since COVID to managing our women with preeclampsia diagnosed during admission. And what we've seen so far, and this is about a year's worth of data, we've enrolled and navigated over 2,100 women through this program. And what we can see is the number of women that are readmitted at 30 days with complications of severe maternal morbidity is significantly less in our patients that have been navigated. And more importantly, in our Black and Asian Pacific Islander population, our rates of readmission, which were around anywhere between 10 and 15% for both of those groups, in the navigated patients actually dropped to no readmissions. Again, this is small data set. We continue to navigate these patients, and we continue to grow this program because we truly feel that patients that get this sort of very focused, very personalized care can actually have much better health outcomes, with much less long-term morbidity for themselves and for their newborns.
Thank you, Dr. Klein and Dr. Combs, for providing the background of this program and the great outcomes that you've experienced and learned from. How do you see this program growing or evolving? What's next? Dr. Klein?
So this is the beginning, and really there are several next steps. One is to fortify our relationships with community-based organizations, to engage more of the stakeholders, get more involved in doulas, because the use of doulas during pregnancy has been found to be very helpful and decreases cesarean rates and improve outcomes. We are working with the Rory Stoughton Foundation to make patients and doctors aware of maternal sepsis. We are working with faith-based organizations, local media, and we're also educating the public with a series of lectures. I think very important takeaways is we need to unravel the enigma of severe maternal morbidity mortality. It really is truly an American crisis. We have to disrupt prenatal care on the national, state, and local level as we know it, and kind of re-engineer it, reimagine it. And we need to provide every mother the best possible outcome and provide safe delivery for both all mothers and all babies.
Thank you, Dr. Klein. Dr. Combs, do you have any final words?
Thank you. I think that we're very excited about the work we're doing so far. We truly want to make a more generalized awareness in the community, not so much our patients and our providers, but in the community that supports our mothers and their families on how important maternal health is for a healthy community in general. So as Dr. Klein mentioned, we've got our clinical work all going in the right direction. We have our database going in the right direction. The next big push is to really get the community involved. And as Dr. Klein mentioned, really look at some innovative models to really navigate and provide much closer individualized care for our patient at the highest risk. And using community healthcare workers, using doulas, recognizing the digital platform and how important that may be to help us to really reinforce and promote healthy behavior is our next steps.
Thank you, Dr. Klein and Dr. Combs, for sharing all the great work you're doing to improve maternal and birth outcomes for your served population. This is another example of how examining and combating disparities in maternal care can lead to better outcomes for mothers and their families. For more podcasts, education, additional tools, and resources to improve outcomes for maternal child health, visit AHA's Maternal Child Health webpage. Thank you for listening.